Degenerative spondylolisthesis is a condition in which one vertebral body slips on top of the other one due to degenerative changes. Now, degenerative spondylolisthesis can happen at any level in the spine, but it's the most common in the lumbar spine. Second is the cervical spine, and lastly, the thoracic spine. Hello, my name is Dr. Grant Cooper. I'm the co-founder and the co-director of Princeton Spine and Joint Center. In this video, we're going to go over everything that you need to know about degenerative spondylolisthesis. The most common symptom from degenerative spondylolisthesis in the lower back is lower back pain. But symptoms from degenerative spondylolisthesis in the lumbar spine can vary from back pain and stiffness to leg symptoms such as leg pain, numbness, weakness. There are two very important points to know about degenerative spondylolisthesis before we go any further. The first is that about 20% of the adult population is walking around today with degenerative spondylolisthesis. And the second important point about this is that the overwhelming majority of people with degenerative spondylolisthesis don't have any symptoms. Now, these data points are very important to know because when patients do have symptoms from degenerative spondylolisthesis, the overwhelming majority of those patients can and will get all better without surgery. Now, to be clear, if the bones have slipped on top of one another, as they are in degenerative spondylolisthesis, then conservative care will not return the bones to their original position. That is to say that getting people all better from symptomatic degenerative spondylolisthesis doesn't require returning the bones to a normal alignment. Now, how is that? Well, let's start with broad strokes, and then we'll get down to the nitty-gritty. The reason that one person with degenerative spondylolisthesis can have no symptoms and another person with the same amount of degenerative spondylolisthesis can be in 24/7 misery from those symptoms, and everyone else will be somewhere in between those two extremes of symptoms, and all of those people can have the same MRI and X-ray findings of degenerative spondylolisthesis, is because it's not the spondylolisthesis per se that's causing symptoms. Instead, it's when the body responds to the degenerative spondylolisthesis with inflammation. And it's that inflammatory response that will either cause pain and sometimes numbness and weakness or not. Now, inflammation is actually a protein response, but the best way for us to think about inflammation in this context is that it's like a fire. And there are two ways that we can put out a fire. One is to move away the sticks and let the fire die down on its own. In a surgeon's world, that means surgery. For degenerative spondylolisthesis, it generally means fusing the two bones together. And we'll talk a lot more about that in just a bit. But most cases, as we mentioned, are cured without surgery. In a non-surgical world, moving away the sticks from the fire generally means exercise. By stretching and strengthening the surrounding muscles, in particular for degenerative spondylolisthesis, this is going to mean stretching the hip flexors and strengthening the core and hip abductors and adductors. Now, the hip flexor muscles are particularly important with this because the hip flexors are the strongest muscles in the body and they attach to the transverse processes in the spine. And so when they're tight, they pull the bones of the spine forward, which is particularly counterproductive if the bones are already slipping on each other. And by stretching and strengthening the muscles around the spine, the goal is to take the pressure off of the spine to allow the fire to hopefully die out on its own. But sometimes that fire just keeps on wanting to burn. And when that happens, you can take a fire hose and you can put out the fire. In this context, the fire hose generally means taking a needle, going under some kind of image guidance, and delivering anti-inflammatory medicine to the site of inflammation. In most cases of symptomatic degenerative spondylolisthesis, taking away the inflammation and the pain with an injection is actually the easy part. You basically deliver some steroid to the site of inflammation, the fire goes out. But then the water always turns off. And when the water turns off, the same degenerative spondylolisthesis is still there as it was before. And that doesn't mean the inflammation will return, but it doesn't mean the inflammation won't return either. So if we use a fire hose to put out the fire, it's important to think of the fire hose or the injection as offering a window of opportunity during which the patient can start tweaking the biomechanics with exercises so that as the medicine wears off, The same forces aren't going through the same parts of the spine, and we should pause for a moment and say, where exactly is the inflammation coming from in someone with degenerative spondylolisthesis? Well, there are three basic potential places for this to be occurring. When the symptoms are back pain or stiffness, the most common reason is because there's inflammation in and around the facet joints. The facet joints are hinge joints that prevent rotation and extension in the spine. They help stabilize the spine, and the wearing down of the facet joints is actually one of the primary ways that the bones start shifting on top of each other in the first place. Now, a side note is that if the facet joints are the source of the pain in someone with degenerative spondylolisthesis, then there's another treatment option that we need to mention, which is to use radiofrequency energy in a procedure called radiofrequency rhizotomy or ablation to deinnervate the facet joints. So it's like someone's trying to make a phone call, but the cord is cut. The joints are still going to be inflamed, but they can't send a signal to the brain, so there's no more pain. Now, the good thing about radiofrequency ablation for facet joint pain is that it tends to work very well, and it's overall a very safe procedure when done correctly. The limitation is that the nerves tend to regenerate in about 6 to 18 months, and then you have to repeat the procedure. And the second most common cause of back pain and stiffness in degenerative spondylolisthesis is from the disc itself. A tear on the inside of the disc can lead to that same back pain and stiffness. When this happens, unfortunately, there's no good radiofrequency ablation option. So from a non-surgical standpoint, it really comes down to removing the inflammation well and then working on the muscles so that the inflammation doesn't return. When the symptoms are in the legs, what's actually happening is that the degenerative spondylolisthesis is making the hole, or what we would call the foramen in medical jargon, where the nerves exit the spine, smaller. And as a result of this narrowing of the hole, this is also called spinal stenosis, there's going to be more of a propensity for there to be an inflammatory response in the hole that leads to sciatic-like symptoms. Now, here again, non-surgical treatment focuses on reducing the inflammation from the foramen and also from around the nerve, and then strengthening and surrounding the muscles to take the pressure off of that hole so the inflammation doesn't return. When degenerative spondylolisthesis continues to cause symptoms despite good, aggressive conservative care, there are very effective surgical options. When the symptoms are in the legs, the surgical options can be divided into two broad categories. The first and the most conservative is a decompression surgery, namely a laminectomy, in which parts of the bone are cut away in order to relieve pressure from the foramen or from the hole where the nerves are exiting. This can be particularly effective in mild degenerative spondylolisthesis. Now, if the pain is more in the back or if the spondylolisthesis is more significant than decompression and a fusion, in which a bone graft and metal screws and rods are used to take the pressure off of the nerves and then fuse the bones in the disc in place so they stop making these micro movements. Now, people are often worried that if they get a lumbar fusion, that they're going to lose a lot of range of motion and not be able to do things later on. A fusion is definitely a big surgery, and it should never be taken lightly at all. But with that said, unless you're a professional athlete, you're probably not going to notice a lack of range of motion from a single level fusion in your back. If you do have surgery, a decompression or a fusion, it's important to note that it becomes even more important on the back end of the surgery to focus on exercises to help support the spine in order to prevent future problems in the spine. So for example, if you have a fused segment in the spine, the motion that used to go through that level of the spine now has to go above and below the fusion, and that puts more stress on those other levels, making injuries and inflammation at those other levels more likely. And this is called adjacent segment disease. It can't be totally prevented, but it can certainly be mitigated with appropriate exercise. So a common theme here is that no matter how you get better, on the back end of getting better, you're going to want to be doing exercises to help support your spine in the future. Thank you. Now, as always, if you have any questions or comments, or if you have any requests for future videos, please leave us a comment in the comment section. And please remember to hit the like button, as it helps us with our YouTube algorithm. We really appreciate your support. If you haven't already subscribed to our channel, then please consider doing so now. Thank you very much.